Hopefully, all right, there we go. We all got the recording notification. We will be recording our meeting today just so that we can share that online with folks who couldn't make it to the presentation. Welcome. Today, our topic of discussion is holistic care for the whole community. My name is Ashley Beck. I'm with Whitworth University, and I will go into a little bit of the committee members, but I'll be stepping into the facilitator role for the Health Services Research Roundtable with Paul Buller's retirement this spring. So we'll talk a little bit more about our membership in a little bit, but welcome. We will hear today from some of our panelists who of their success and challenges in innovative care models that are designed to integrate different aspects of healthcare into the kind of primary care system and a more whole person aspect, a model for healthcare. So we became interested in this topic just because of the pandemic has really highlighted the need for integrated care between things like mental health and physical health and primary care. So the idea is that behind this innovative model is that something closer to a one-stop shop where we could, Amy, you can kind of go back to the beginning one. I haven't started going through all these yet. I don't have a slide for this. The idea being that when referrals are provided, that those be warm handoffs and that we do as much as we can to reduce barriers for individuals needing healthcare access and different kinds of aspects of healthcare, from mental health, social work, nutrition, dental, and therapeutics like occupational or physical therapy. I'm from an occupational therapy program, so have to include all of our therapeutics. All of those things are things that we know impact the health of the whole person. So that's really our concept and what's kicking us off today. Amy, if you want to go back to slide 2. Okay, here we have our Health Services Research Roundtable Steering Committee members. We have a little bit of history. The Health Services Research Roundtable was initiated, we'll go into some of it, but was co-founded by Paul Buller and Brenda Stevenson Marshall with Gonzaga University as a partnership between their School of Business and their School of Nursing. That evolved to include community partners, including the health district and many other community kind of partnering organizations who've connected to the HSRR over that time. And to now include, it's expanded to include all of our academic institutions in the Spokane area. So we've got this great roundtable mix of leadership representing each of the schools and all with a common goal of connecting us to each other, those of us doing similar work, and connecting us to community to do truly impactful kind of community-based work within our Spokane area. So that's really the mission of our Health Services Research Roundtable. You can kind of read off our membership here. We have several new members of our steering committee starting and some turnover happening right now, which is really exciting because we'll kind of have some new energy to our committee. Can you go to the next slide, please? Special thanks to Amy, who's running the slides and for the logistics behind today's event. Amy's with Gonzaga University School of Nursing, and she's just done a great job of putting all this stuff together. So thank you, Amy. You go to the next slide. And thank you to Paul Buller, who didn't want me, I think, to include this slide, but I'm going to. And I'm so glad Brenda's here today as well. But Paul Buller and Brenda Stevenson Marshall were the co-founders of the Health Services Research Roundtable. And Brenda retired just a few years ago from our committee and is here today and still participating, which is just awesome. And Paul, congrats from all of us on your retirement coming up this spring. And we hope that you are joining us in your retirement as well, and that we still get to stay connected to you, but enjoy your well-deserved retirement. Can you go to the next slide, please, Amy? All right, so here's just a little program for today's event. We have a panel facilitator, Patrick Jones with Eastern Washington University, will be facilitating us. We have a great panelists here today who will speak about their perspectives in innovative care models. Dr. Philip Hawley with Yakima Valley Farm Workers Clinic, Samantha Clark with Multicare Behavioral Health Network, and Ryan Keeley, I hope I'm saying your name correctly, with Excelsior. We will have time for questions, but I ask that everyone who is not a panelist or a facilitator to please mute your microphones, and we will get started. I'll hand it over to Patrick.
Thank you, Ashley. Before we get started with our panelists, I'd just like to give you a flavor of who we have on board today. I think we've got a great lineup, as you heard from Ashley, and I just want to give a little bio for each of them. So we'll start with Samantha. Samantha Clark is the Associate Vice President of Strategy and Business Development for MultiCare's Health Systems Behavioral Health Network. And in that role, Samantha is responsible for the development and execution of strategic planning and business development initiatives for the MultiCare Behavioral Network, which is Washington's largest behavioral health organization. And among the many charges she is tasked with is the creation of new clinical programs and partnerships. Samantha moved to Spokane, and she is one of our two Spokane speakers in 2019, where she's also responsible for managing behavioral health operations for the Inland Northwest region of MultiCare. Samantha's academic background is a bachelor's in psychology from Western Washington University and a master's in healthcare administration from the University of Washington. Samantha was a social worker prior to going to graduate school and started her healthcare career a decade ago with foster kids in behavioral rehabilitation. She and her partner are enthusiasts of Spokane outdoor offerings, and they are equally fond of Spokane's brewery scene. So sorry, Samantha, we can't offer that to you today, but maybe we'll see you at one of the local shops. So alphabetically next is Dr. Philip Hawley, and Philip is the Primary Care Behavioral Health Director for the Yakima Valley Farm Workers Clinic. He is a licensed clinical psychologist who has worked in primary care for the past 8 years. Philip manages the Primary Care Behavioral Health Program, consisting of behavioral health centers across both Washington and Oregon, who provide behavioral health services within the patient-centered behavioral health model of integration. Among Dr. Hawley's many roles are, as director, are providing site visits and ongoing support of behavioral health within the organization, reporting to internal and external stakeholders, supervision of the behavioral health postdoc residents, hiring, onboarding, and training of newly hired behavioral health specialists, and the offering of in-service trainings to assist mental health concerns to staff and community. Philip and his wife reside in Natchez, Washington, and coming to us from either Natchez or Yakima today. So welcome, Philip. And certainly last but not least, alphabetically, is Ryan Keeley, who is the Executive Vice President of Excelsior Wellness, which is an integrated homegrown, that is Spokane grown, healthcare system providing primary care, behavioral health, and education services. Ryan's work places him at the nexus of many public and private systems supporting general health integration. Ryan holds a bachelor's degree from Whitworth and a master's in applied psychology from Eastern Washington University. Outside of work, Ryan enjoys spending time with his family in all the areas that the Pacific Northwest offers. And Ryan, we're going to start with you. And for everybody on the line, what we've arranged now is about a 12-minute presentation for each. And that will be followed by a leading question from yours truly. And then we will go on to questions from the chat. So Ryan does not have a PowerPoint, so we'll just put the camera right on you, Ryan.
Terrific. And I'm glad the camera's right on me. We've gone 2 years of Zoom, and I just now bought a light that matters. So, you know, right as we're going to be hopefully out of this. So it's great to be here today. Yeah, you know, and I'm prepared. Great to be here and with these great panelists. It's important I think, to start with Excelsior's integration and whole person care story. In 1982, when the Good Shepherds transitioned care to Excelsior at our founding, we started with a medical care coordination clinic on top of the residential services that we had. And that was out of a need of what we were seeing with really acute behavioral health concerns. They certainly didn't call it behavioral health concerns there we've later added that terminology. That same care coordinator still works at Excelsior, named Sue Bell. She's been there for 42 years. Wow. There was no identified payment model for that. So in a sense, it's what we're striving for now, which is an alternative payment model, and then layering on services that actually matter for the populations that we serve. And so that has set a foundation of our culture, is that we want to look at the populations that we serve and then overlay the services that are really necessary for that population. What that's led us into now is in an expansion into a couple different sectors. One, we talked, or in the intro, talked about primary care. So we have Excelsior Family Medicine, which is an integrated behavioral health and primary care clinic, and that serves the mild and moderate population. We also have our Excelsior Integrated Care. That's our inpatient continuum, more acute behavioral health concerns. And what we do there is provide access to all of our other services in a priority setting. So if a youth is in one of those programs, they also have priority access to our other continuum of care, because we should respond to their holistic needs while they're in that service. Excelsior Wellness is our certified community behavioral health center, and that has our continuum of behavioral health services that are outpatient, from outreach, care coordination, all the way up to more significant wraparound teams or intensive outpatient programming. Our Excelsior Holistic Schools is an elementary, middle, and high school program. It also has vocational integration, so we can respond to the needs of the family in that way. And in our recovery continuum, there's access, again, priority access to our family medicine clinic. We have an on-site MA to our care coordination, and then a fully integrated behavioral health team. So we've been joking on our team that integration's hard work. One, because the funding mechanisms haven't really caught up. We sort of like to say in healthcare that we are providing the care that we need, but oftentimes we provide the care that's paid for. And so that evolves our practice too much. And so we're trying to lean into that space and develop the models and let the payer mechanisms catch up to us. And so we rely heavily on a braided and blended funding model in order to achieve that. And in some ways, it's like I've come to describe that payment model as like trying to braid rattlesnakes. You are going to get bit because they don't play nice together, and they certainly do not want to be braided all the time. And so that's how we're able to pull some of this off, but it certainly has some challenges built in. Hold on just a second. Oh, and I didn't hit my timer like I was supposed to. Okay.
I think you're about 4 minutes in.
Oh, perfect.
Yeah, you've got time.
I can go on stories.
Keep on going.
Yeah, good deal. Some of the context or the reasons that we do this is because we really believe that integrating behavioral health and integrating primary care into more context in our community is going to improve access that's desperately needed for mental health. If you look at the statistics, about 50% of people with an identified mental health disorder are actually getting care. That's abysmal, knowing that that's driving some of our most costly deaths in our community, from suicide and the opioid epidemic. So it's a real failure of our system to not fast forward some of these initiatives. We also know that staying unintegrated is far too expensive. We know that it's going to reduce costs in the long run if we make these investments in the primary care space, and we can reduce savings. But in some ways, it's like if you go shopping and you buy, like I started to think about it, like sometimes you go shopping, you buy something on sale, you feel like you've gotten a deal, but you still spent money. And I think that's where we're at in the primary care behavioral. Everyone thinks that it's this great idea, we should be doing that. And then when people actually try to implement it, they find that the funding mechanisms really haven't evolved yet to the degree they need to. And the studies are really astounding. One more point on access. It's even, I had said a mental health statistic, but it's even more of a problem in the substance use space, which gets me to my third reason that why we do it, is we believe that we can really use the primary care clinic to decrease stigma around mental health and substance use communities. If you think about your experience in primary care, we go there and we are able or willing to talk to our primary care doctor about a rash in a very intimate place, right? And we usually describe it accurately. But if that same primary care clinic asks you how much you drink, if you're like anyone else in America, you're going to underreport it by lots of drinks, or you're not going to fully describe your suicidal or the depression symptoms that you're having. And so the more that we can put it in that primary care space, which is trusted in our community, we can hopefully decrease the stigma. So people are going there to get the care that they need. If we continue to develop the throughput, the access after that screening and those preventive services have occurred. So when we think about integration, we're starting to get categories of where we integrate. So I've talked a lot about primary care, and again, that's where we see our mild and moderate and prevention and screening. What we want to do is get everyone at least a well visit yearly, at the minimum. And at that visit, it's really important that we're doing good behavioral health screening, and then we have the appropriate access for when they do disclose those symptoms. So we've worked, our medical director is working on our team. She's doing a terrific job, Dr. Tara James, at creating collaborative care models, creating interdisciplinary team meetings, and so we can get people the care that they need once they have been identified as needing that mild and moderate care. We're also integrating paraprofessionals in that space. And this is an area where I'd love to see more research because we don't have to have licensed mental health therapists doing some of this work. A lot of it can be done by peer support specialists, care coordinators that are well trained in identification of some of those extreme behaviors that we're talking about and helping navigate people to the right place of service. And that's particularly important because not all payers really identify those professionals within their fee schedules or within their credentialing processes. It's within maybe a Medicaid space or some other things. So it's really important that we're building a cohesive delivery system and not building these models that are only fit for some payer models. And the second area is the behavioral health integration. We talk a lot about getting behavioral health into primary care, but what about getting primary care and health service into behavioral health? Once people, oftentimes they have a lot of contact with behavioral health professionals, especially if they have serious mental illness, and so if we can train those folks in bi-directional integration, get them access get them connected to the clinics with their trusted behavioral health professional, that's going to be really important. And I think we're going to see a lot of gains, and we're doing that. One of the ways we've done that is in our family medicine has become a center of excellence for foster care. What we did was we established different priority access points, different training that are required for those primary care providers, so that we have availability, we have trained people to serve that specialty population, and it has been a wonderful experience. The third is we're working on robust sort of school-based integration. We're the first school-based health center in a charter school in Washington, and that's with Lumen School, and we have care coordinate, we have a behavioral health team, and then also which consists of paraprofessionals, care coordinators, peer support, mental health counseling. And then we also have 1 day a week, we send a provider down there. And it does not work well in a fee-for-service environment, because what they're doing is building relationships with this charter school serves mothers and their mothers, fathers, and their kids in high school. And so you're building relationships so that when they're ready to really talk about some of their health needs, you have that access created. So it's a different way to deliver services, but it's really rewarding, and we're seeing a lot of great benefits from that. When we think about research, the things that I would love to see is a bit better operational definitions and some common terminology. The integration can mean a lot of things, or innovation. So what are we really talking about when we're having a clinic set up with different paraprofessionals or behavioral health. I think that's going to help drive practice models and evolve them a bit better. I also think it's important that we get the true cost of transitioning our entire system to these models that we know are effective. There's going to be more upfront costs given, and we need to know what those are. And some of it's known, and we can talk about that later. But I'd like to know about that. And then how do we integrate some more paraprofessionals? This is done throughout the health system, I think, in a much better way with medical assistants, with different care corners within hospitals. But when we talk about it in a primary care space and some other settings, we pretend like we don't really know that we've ever done that before, but it's just some different names. And so how do we research who really are these professionals and where can we put them within the system? And that is 11 minutes.
Yeah, you did that very well according to our request, Ryan.
Yeah.
So thank you so much. I've taken a few notes, and we're going to circle back after we hear from the other two to pose some of these questions to you that I'm sure others have besides myself.
Great.
Thank you so much. All right, next up is Samantha. Samantha, are you ready to roll?
I am. No, I'll try not to say like 80% of the same things. It's almost like people with similar experiences are here talking about the same subject.
It's not a bad thing.
So hi, everybody. I'm Samantha. I work for the MultiCare Health System. And for the purposes of this conversation, I'm really going to scope down what holistic care means for us to really the behavioral health service line, and really the behavioral health service line in the outpatient setting. Just a brief bit about MultiCare. We're fairly new here in the Inland Northwest. We have Deaconess and Valley hospitals, as well as a freestanding emergency department up north, and then Rockwood, which is a multi-specialty medical group. On the western side of the state, which is where our legacy started, we're about 11 hospitals strong. We have within behavioral health, what is a network of historically 3 separate community mental health agencies. And so you might recognize them. In King County, that's Navos. In Pierce County, that's Greater Lakes, and what was historically called MultiCare Behavioral Health. Each of those brands operate differently, but they're all a part of the MultiCare Health System, and that's what reflects network when you hear that term. We're also 50-50 joint venture owners from a 120-bed freestanding psychiatric hospital that we built with CHI Franciscan, and that's called WellFound. And then outside of those outpatient services, which are through the lifespan, mental health, substance use, virtual and in person, we have 2 adult residential treatment centers in Pierce County, 1 freestanding 16-bed ENT, an adolescent behavioral health unit, Gero unit, and an adult unit that has some capacity for medical complexity, as well as a 76 freestanding psychiatric hospital in King County. And we're growing. For us, integrated behavioral health care has looked a little different. It probably started a little over a decade ago with sharing systems. So electronic health records, trying to compare reports and coordinate with our primary care partners, really what I would call passive collaboration. A little less than a decade ago, we integrated, asterisk there on integrated, clinicians, behavioral health clinicians into different primary care clinics throughout the Puget Sound region. But really all we did was create a co-located model where they're doing the traditional psychotherapy with 50-minute visits with their door closed the entire day with little to no room for collaboration with their primary care partners. We've dabbled and expanded that model as we've grown. And I'm very excited that this year we have 9 different FTEs, so 9 different clinicians that we're going to further integrate into pediatric practices, as well as adult primary care, family medicine, and internal medicine clinics. That model is the collaborative care model. So when I say collaborative care, the model specifically developed by the University of Washington Ames Center. that's where we've been to where we're at, sort of teetering. I think through the rest of 2022 and beyond, we expect to grow collaborative care, and not just in pediatrics and primary care, but also to look at specialty care. You know, this is a program that's relevant for endocrinology, hematology, oncology, women's services. I'm a person living with type 1 diabetes, and I can tell you when I was diagnosed at 24, access to mental health services would have been great, but it was not even considered. And that was even at one of the best medical systems in our nation. And so we're a little far behind in access to mental health for specialty providers. I think that there's also great room for us to consider multi-tiered integrated programs. So much of integrated behavioral health and primary care is around the front door, but there's not often consideration for what happens after that. What happens after your brief intervention, your 6 visits, your 12 visits? What about the individuals in our community whose needs aren't satisfied in that short amount of time? And so creating an open door, high volume, high throughput, high helpful integrated model that has access and care coordination opportunity for longer term behavioral health services. Here in Spokane coming up, I'm very excited. Y'all might have heard about it, but at the Northeast Community Center, we will be building a behavioral health clinic in what was the old library building. And it's exciting to think about what behavioral health integration in primary care can do, but I'm so much more excited to see what behavioral health within a campus that does have primary care and a pharmacy and a dentistry clinic, but also SNAP housing, early Head Start, community classes, WIC, it's next to a middle school, a senior center, an elementary school, really in a hub where there are already so many wraparound services there for the community to access. And so stay tuned. I think that that's going to be a model that's a little novel today, but hopefully will become more normal in our healthcare system and our community system in the future. And then I would say on the 2023 sort of horizon, using data to drive decisions. I think that that's one of our challenges in our field, is that we believe in the narrative that behavioral health integration reduces total cost of care, but we are not very good at producing replications of that narrative with our own data. And so as we look at growing the collaborative care model, like growing other community models of integrated behavioral health, collecting that data, being action oriented with it, and then using that in a population health mindset to illustrate the impact so that we can ultimately get away from those complicated braided rattlesnake funding mechanisms and hopefully get more into a value-based payment arrangement. Challenges, I could probably, let me check my timer. I could go on about challenges. Of course,
you're fine, Samantha.
Of course, there's always workforce shortage. Really considering how we can continue to expand licensure. I totally echo, peer specialists, bachelor's level folks, master's prepared, associate licensed, fully licensed. There's a broad swath of individuals who I think are poised well to support patients or clients in these programs. What I don't see is that broadness reflected in the individuals that can help them along the way. I have a master's in healthcare administration, and there are very few programs that will allow me to supervise an intern. And if we're asking for well-rounded interdisciplinary clinicians, then why aren't we reflecting that interdisciplinary management and who is helping them through their internship? I'm not saying we pull away from clinical. I know that would make a lot of rooms for me, but I'm saying that more shared responsibility to help that student, once they become a clinician, be successful in an interdisciplinary way is something that I think is an opportunity. I will call it like I see it, and also say that the education of our medical partners is also a gap that I see. Oftentimes we hire a behavioral health clinician, we put them in a clinic and they're an island. Oftentimes they feel like an island because they are misunderstood. There's a lot of bias and stigma that we're trying to break down by integrating behavioral health for our patients. And there's a lot of bias and stigma within our teams that our behavioral health clinicians still feels. I think in general, our field is often misunderstood. And so we see that in our turnover and our challenge in retaining individuals, as they do not feel that they are respected. They do not feel that they're collaborated with. They feel like their job is to take primary care's problems and to make them go away. And I know maybe that's not the kindest way I could put that, but that's what we hear. And I think that getting into the curriculum of providers, helping them understand and value behavioral health and seeing how they can work as a partner with us would make a really positive difference in the field. I would love to see more system integration. In our healthcare system, Epic is law, Epic is God, Epic is our electronic health record. If it doesn't happen in Epic, it didn't happen ever. And it makes it very challenging for us to be nimble and between behavioral health and primary care, specialty care, community partners, share information, be efficient, coordinate referrals. Because again, if you can't fork up tens of thousands or more dollars to integrate with an Epic, we're probably not going to play with you. And that to me says that we have a broken system that doesn't support healthcare integration. I think that in terms of research, I would love to look more at interdisciplinary coursework and curriculum. I don't know what the research question would be, other than I feel like that's an opportunity for students across specialties, across programs within a university to try out and investigate. I would also love us to model more. Again, the narrative is that if we have high throughput, brief models, that fewer people will need care and we can serve them longer, and fewer people will need inpatient, but I have not seen that done with community organizations here in Spokane. I have not seen that done well with organizations in Washington State. And I believe that this community is the right size and has the right services to measure that and research that over time. And again, I would love to see more data-driven efforts with students. I'd love to see more research on outcomes and how to use data to drive decisions in a predictive way instead of a reactive way. So those are three things that as someone on the outside and on the inside and upside, downside, all around looking at this problem are three things that I would call out as opportunities. And I think that folks like yourselves, universities like the ones that you represent, organizations like the one that you represent, they're the right folks for those problems or challenges to be communicated to. So.
Oh boy, I took a lot of notes there. We'll have to come back and ask a few more questions of you, Samantha. You got some good ideas and definitely some hard-won insights, I think. So just a reminder to everybody to be thinking about questions as we're wrapping up now with our third presentation. And I think the best thing to do, even for a group of 40, is to put your questions in the chat, and I'll take them, we will take them as they come in and see whether we can get some answers. So with no further ado, let us go to Dr. Philip Hawley in Natchez or Yakima, Washington.
I am at home today, so I'm over in Natchez, although my office is in Yakima. And I'm going to pull up some slides to kind of guide me through my conversation. So can people see this? Okay. All right. So I am the primary care behavioral health director for the Yakima Valley Farm Workers Clinics, and kind of give just a little bit of kind of my background. As Patrick shared, I am a clinical psychologist. I'm from the state of Missouri and completed my undergrad at Truman State and then went on for my PsyD at the Forest Institute of Professional Psychology. I'm a bit of a rare, although I hope a growing trend in psychology, in that I've done very little traditional psychotherapy. I began in integrated settings back in 2012 and really have just been a big part of that for my whole career. I was able to even go out to my internship in York, Pennsylvania, and there was part of some of their integration efforts, and then came out to Toppenish, Washington, where I worked as a integrated behavioral health consultant for 5.5 years before becoming the director in 2020. So over that time, I have been able to have somewhere north of 9,000 primary care visits in Washington and Oregon in our clinics. Show kind of a map here of what that looks like. And that has been across kind of all the different primary care departments, such as family medicine, OBGYN, and internal medicine and pediatrics. So this is what our kind of bigger area looks like. And so what we have is probably for those in the eastern area here, more familiar with our Unify clinics in Spokane, at West Central, Mission Avenue, and the Northeast Clinic. And we actually stretch all the way down to Salem, Oregon. So our organization has really grown in regards to even what this means in terms of underserved populations, as we began working with migrant farmers in the Yakima Valley, but really understand that those underserved patient populations and barriers to healthcare apply to people way beyond migrant farmers. And we're seeing that certainly in more urban settings, and we're seeing that really across the entire Pacific Northwest. So as we've continued to grow, we are now up to 24 positions, and then me who kind of manages over that. And we continue to put behavioral health consultants as part of the primary care behavioral health model into our clinics across the whole organization. Wanted to share a little bit here. So we do the primary care behavioral health integration model, and a big way of kind of ensuring fidelity to that and making sure that we're staying consistent to what that means is using the GATHER acronym. That really allows us to look at things like being a generalist. So we see all ages, everything across the mental health and substance use diagnoses, as well as physical health conditions with a behavioral change component. We want to make sure that we are accessible. A good way we kind of look at this is trying to ensure that we are seeing about 50% of our visits same day, through a warm handoff model. We want to be part of the team. Being in primary care is something that comes with some adjustments. It's an entirely different culture, especially compared to specialty behavioral health. And we really want to find ways to be a part of that team and enhance the entire primary care process. In doing primary care behavioral health, we also need to make sure that we are really kind of exceeding some of the productivity of what a co-located therapist would be able to achieve. So we typically are thinking of somewhere around the 10 visits per day as an indicator of high productivity. We want to be educators. We want to be people who in the primary care space, we're seen as experts in behavioral health. And that as a part of that, we can also be teaching our coworkers and our colleagues to better understand behavioral health topics and to use those types of perspectives in the care that they have with all of their patients. And as I think it's kind of been mentioned really well throughout everybody here so far, is integration, as much as we have learned a lot, it's still relatively new. And so we're still figuring out kind of what this should look like. What are routine pathways? What are workflows that really allow for behavioral health in the primary care space to be normal care? And we want to continue to kind of make sure that that's something that is improved over time. We are always kind of using this brief model. Our visits tend to be around 20 to 25 minutes with patients. We typically will see people between 2 and 4 times. And a big part of that is we're also really viewing ourselves. I stick pretty strongly to the word consultant in BHC, as we do view the primary care providers as kind of our primary customer, and that our goal is to really help them in the management of their patient panels and what that looks like for our entire patient population. So for us in 2021, this is a big part in I'll kind of loop back around to where I see this as some of our strengths and some of our challenges. But we see a large number of people. We see over 8,000 different patients in 2021. This was a team of, I had some turnover in 2020 and 2021, but probably about a dozen people to see over 8,000 different patients. We're able to see large percentages of the entire clinic population, and that can even exceed 10, 15% of all patients coming into the clinic having a visit with a BHC. We're able to generate a large number of encounters with our 14,575. And we also track additional things, as Samantha mentioned. This is all that other Epic stuff that we keep track of, because if we don't keep track of it, it didn't happen. We call those touches. And so they're just additional patient care activities that are documented in Epic to really get to this point of over 20,000 patient care activities being conducted by this team in a year. So some really great things to kind of look at the breadth of what this is and our ability to kind of impact an entire patient population. The other part to this is my team kind of came back to me last year and they said, we love to see all the numbers, we love to see this stuff, but how are we really kind of having an impact with patients? We want to know more about the quality of our work and not just the quantity. So last year we took on a big project to gather 12-month data from some of our patients with diagnosis of depression or dysthymia. And we looked at their PHQ-9 scores from 2019 through 2021. This began with individuals who had a positive screen for depression, could have been done at just kind of their annual visit or at other visits where depression may have come up. And if we can kind of see this here, I just want to kind of keep the basics here. So we don't need to kind of review this too detailed, but the thing I wanted to really kind of show is what we were able to see with this is it very much reinforced some of the things that we know to be true about primary care behavioral health. And that is many people are able to see improvement relatively quickly. We saw that in the amount of time that we were spending with patients, that as we kind of move to the bottom left on this chart, we're seeing individuals who had less time with the BHC, but we're also seeing significant reduction in PHQ-9 scores. And this also correlated, as you would expect, with visits, in that our visits do tend to be in that 20 to 25 minute range. And so within that first 2 to 4 visits, we saw a great chunk of people who really showed good improvement on their depression symptoms. And so if we look at this for this kind of bottom left screen here, what we see is individuals with clinically significant improvement on their depression symptoms. And all of this was happening in about 4 or less visits or 85 minutes of intervention or less. I have seen this story come up a few times on just different platforms recently, and I feel like I'm going to butcher the actual story, but I will tell kind of what I pulled from it. And really what I kind of got from this story was, how do we look at data? How do we start to see the things that we're doing? And in some ways, how can data kind of lead us astray? And so the story with this was that during World War II, there was an analysis to start looking at where airplanes had been shot in an attempt to better reinforce the planes. And through this analysis, basically what people are missing is the planes that were returning were the planes that made it through combat situations. And so by reviewing the data of a plane who's made it through combat, we're actually missing some of the opportunities of what data is most important. And so instead of looking at where these planes needed more reinforcement, what we really want to be looking is where these planes don't have bullet holes, because those were the types of hits that actually led to the crashes on the planes that didn't return. And so I think this is such an important part, whether we're looking at different integration models, healthcare tracking, population. I just think there's such a huge benefit here to start to shift away from looking at just the success of a population or a target population in what we're doing, and start to look at what's happening in the group outside of that. that instead of looking at the PHQ-9 scores for a group that saw BHCs, we maybe need to look kind of outside of what's really going on there. And so this is the type of stuff that I think is so important as we start to look beyond kind of where we're at now. We have some information that really shows some of the things that we can do that can be helpful for some people. But if we're looking at big groups, big populations, individuals that are coming into primary care, Medicaid population groups, I think all of those types of things really mean we need to look at those individuals who aren't responding well to treatment. We need to understand why certain people maybe have seen a BHC many times and aren't improving. We need to understand why some people aren't coming in at all. And we also need to understand why some people are getting worse. So there's these other areas in what we're doing that I think this is really the huge part of where research can go, is to not just look at the success cases within a big population, but start to ask some really critical questions about why this didn't work for everybody else. We need to look beyond what we're measuring and start to look at just the whole patient population to figure out, what do these other groups need? Do they need something more? Do they need something less? Maybe they need something completely different. We need to find how our integration attempts actually fit together in a way to treat the full patient population rather than targeting small groups with specific interventions. So I kind of really feel like this quote kind of matches that up, but it's that exact idea of really inverting this. Let's not just look at what's going well, but step back and look at the big picture, and also kind of dive into these areas where we're having challenges and understand those challenges in a very curious and kind of energetic way, because those are the areas we need help. We need to know what works for people that didn't work with the previously tried strategies. And so I think that's kind of my big focus for all this stuff, is it's such a great idea of how do we look at the big picture? How do we look outside of our tunnel vision and think about everybody? Because the success of everybody is really what impacts these communities. It's what impacts population health.
Philip, thank you. Thank you so much. So please, everyone on the call, in the meeting, would you start thinking about the questions you want to pose to the folks here? I'm gonna have a couple rounds of questions, one that I get to pose, and then I'm gonna ask our presenters to ask each other a question that they would like to see. But my question for all of you is, if you were to look at your crystal ball over the next 5 years in each of your organizations, where do you think you will be with the integration of these efforts that you just talked about? And we'll start with Ryan first, and then Samantha, and then give Philip a break from talking. And again, the question is, where would you like, not where would you predict you'll be, but where would you like to be in 5 years with this effort of integration? So Ryan, can I put you on the spot and see if you can answer that one?
Yeah, that's a great question. I've got my little gamer get some better sound quality here. Yeah, that's a great question. I think to the point about representing our work, we've got a great research team led by Dr. Anna Tretzter, and she's terrific. And if we can get better systems for collecting and then representing that data so we can continue to drive our practice, I think that if I could have a crystal ball in 5 years, everyone in Spokane would have not just a well visit and not just a teeth cleaning every 6 months, but they would have a mental wellness visit where the goal wasn't to identify disorder, but was just go, hey, what's going on in your life? And then we could identify disorder, but we could also talk about any developmental changes, anything coming up, kind of do the teeth cleaning for the brain.
All right. That was short and sweet, but to the point. So Samantha, what would be your desired crystal ball within the next 5 years for this integration?
Yeah. Big, hairy, audacious goal number one is that I'd like an integrated behavioral health resource Well, I'll leave that intentionally a little vague, but an integrated behavioral health resource for every clinic that we have in our healthcare system. And I think that we use a broad array of backgrounds and clinician types, and we lean on the hybridization of technology and virtual support. And I think that all of these services need to be supported by technology, whether that's apps with asynchronous care, push notifications, check-ins, screenings, content, or just ways for people to engage outside of the therapy room to facilitate further. And I would hope that those push notification screenings and touch points are predictive and based off information that we're using, an algorithm set to predict when somebody needs care, to intervene on time, and that we're using that data like we are in other areas of the healthcare system. And that everybody who's an integrated behavioral health clinician is working on a livable wage wherever they are, because in community mental health, that's not always true.
All right. Thank you. And we'll circle back to Philip. What would be your crystal ball, desired crystal ball over the next 5 years, or by 5 years?
I feel like it's cheating to say what they said. But I think where I think the balance is not necessarily in a want, but a importance that the technology space is advancing into what this looks like. And we have to be a part of that conversation. It needs to be something that we have been gathering all this information into health records for decades now. And we need to start using that intelligently. And I think we need to start partnering with technology to understand how it can help us. We have been screaming now, certainly through the pandemic, but even before that, about how there is not enough people to do the work that needs to be done. And there's a reluctance to let our computers help us. And I think that's what is going to have to change, is we're going to have to find ways to get along and trust technology to help us in specific ways so that we can still do the patient care activities that technology can't help us with. But we're gonna have to find a way to work together. And I think that's where we're headed.
Okay, also short and sweet. So some food for thought for those of us in the audience who might be able to assist in those efforts. So hopefully some of you on the call will have some further thoughts about that. But before we open it up to everybody, I just wanted to go around the presenter room and start with Ryan and say, Ryan, do you have any questions of either Samantha or Philip that might help your work at Excelsior move forward?
Yeah, I think, how do you see system alignment work better? Because we're all in different integrated settings, but another layer of that is integration of those systems. And so how are you thinking about how that might be accomplished better?
One of you want to take a stab at that?
Just waiting for my dogs to stop barking. Sorry, I don't want to continue. One of the things that I think technology, to Philip's point, is really good at, and now I wish my dogs were cute and small as they barked, is connection. So if you develop an app, there's an API connection that you can have that would connect that app to another app, and to the user, it feels seamless, transitioning from one app to the other. We don't do that at all well in healthcare. And so there's got to be some parallel ability between EHRs, between call centers or intake teams to provide real-time communication, easy and efficient transfer of information, and a closed loop feedback so that Ryan, if you're referring someone to multi-care or we're referring someone to you, that's real time and complete, not a duplicative administrative burden process like it is now, or super manual, and God forbid uses faxes.
Yeah. Sorry, I will be quiet.
No, I think that to me is one, just that real-time integration, a plug and play like that would be so great. And then we can start looking at, once the integration platform is there, how do we then right size comparable data points? And PHQ-9s and GAD-7s are gold standards, but is that right? Is that the right data that we should be collecting and comparing? Are there other things that are more broad, to Phil's point, that tell us more of the story that we can be aggregating together to help us inform treatment and how we can collectively work and target populations that maybe aren't thriving or aren't accessing care?
All right.
Well, I just want to add one thing, because I think the point of stigma was brought up earlier, and we stigmatize behavioral health and substance use ourselves. There's been so much conversation about how we assume patients don't want us to talk to their other care professionals because of their privacy. We need to actually open up the conversation to people about what do they want shared. And in some cases, I think people are going to want a improvement in quality of care by having their care team work together. We can't just assume that because I'm a behavioral health provider, my patients don't want me talking to their doctor or to their specialist or to these other people. And so I think for a long time that stigma has come from patients, but it's also come from the professionals who just assume that because it's behavioral health, it needs to be hush hush and we need to lock it up and keep it in this extra secret space that sometimes prevents good care from happening.
All right. Well, hope that answered a bit of your question, Ryan. And
Yep.
We'll shove on to Samantha. Do you have a question for your two fellow panelists that you'd like to pose? You don't have to, but if you do.
This one's, I do. It's pointed towards Philip, and it's a little selfish. Hey, so we're going to be neighbors at the Northeast Community Center, and actually one of my Wazoo pre-psychiatric mental health practitioner students he spent some of his time doing clinicals at the Northeast Community Center and absolutely loved it. And so I'm curious, Philip, sort of a reflection of Ryan's point, in a model like yours, how does another provider of behavioral health service supplement what you do to help you be even more successful?
Yeah, so that project that we just looked at so much hits on exactly what you're saying, because we know that there is a group of people that the more time we spend with them isn't helpful for them, and it isn't helpful for us, which means it's then not helpful for everyone else we're not seeing. So that transition of who is best served in primary care and who needs that stepped up care is such an important part that I don't think we have really defined very well. And I think one of the other things you brought up that I love kind of this part of the conversation is, why can't there be interorganizational supervision and training and support in a way that actually benefits both of us? Like, why is it that because of the logo on my name badge, I can't help somebody with a different logo on their name badge? And so I think, again, to what Ryan was saying too, inter-system support is so important. And I think we all know within behavioral health, there is not a shortage of work to go around. And this perception of business competition, to the extent that sometimes gets discussed, I don't think is quite as imminent as people may think it is. And if we can train each other to work better together, sometimes sharing those resources, that may mean that I could offset a few hours of supervision so that your therapist can see a few more patients that I can transition out of primary care and into specialty care. So that is what I would love to see. And I think sharing a physical space makes that a lot easier. So we need to talk more, for sure.
All right. Ryan, do you have any quick comments to Samantha's question?
Nope.
Nope. Okay. So then before we open it up to the questions that are coming into the chat box now, Philip, do you have any questions of either Ryan or Samantha that you'd like to pose?
Yeah, well, I think we're trying to think of the best way to kind of vocalize some of these things. But for me, I felt like when I first got into the integrated space, there was this real turf war between specialty behavioral health and primary care integration, in this idea that somehow integrated behavioral health professionals were coming for the traditional therapist's job. And I just want to know, like, from your guys' perspective, like, how do we maintain a healthy relationship with all levels of specialty behavioral health? Because we need every aspect of this to function at a high level for it to be successful. And I think that idea where if I'm seeing someone in primary care, somehow I'm taking an outpatient therapist patient away from them. Like, I think we have to be more vocal about that's not our goal. And in many cases, we want to facilitate more referrals to the appropriate sources.
So your question to Samantha, is that a question to Samantha?
Yes.
Or to
How do
Ryan?
we do that? How do we maintain healthy relationships across the full spectrum of behavioral health?
Okay, Ryan or Samantha, anybody want to take a stab at that one?
Sure. I think that it's important, this idea of scarcity, that there's not going to be enough people seeing, is just, try to get a therapist right now and they won't really call you back because wait lists are so long. And so I think also the research and university institutions on the phone or on the line are going to be really important in developing different professional pathways for people. So as these models get more identified and promoted, that's going to be important. It's just a different pathway. It actually opens up the field to recruit more people, because not everybody wants to be a psychotherapist for 50-minute sessions. There's people that want to be more active and involved in the clinic, and we need to recruit those people. We need to advertise for it and let people be aware that there's a lot of diversity within the field.
All right. Thank you,
Yeah.
Ryan. And Samantha, your thoughts on Philip's question?
Yeah, I mean, we're in the middle of trying to answer that. As I mentioned, we've got what was historically a co-located team, and they do the traditional long-term therapy, where there's little to no panel. They see folks for as long as they're willing to come back, and that's how they were trained. And where we're at right now is an and also, not an either or, with our integration growth. While we can make improvements still in practice management with that team, it is true that in addition, there are improvements that we can make for the continuum. And so trying to coach and educate from the point a referral is made from the medical provider, like, this needs to go to your high throughput, highly accessible team. If that clinically is not appropriate, then that goes to your longer term, higher acuity team. And it's through that alignment and education of both our behavioral health clinicians, our medical providers, and our patients, where I think we can get top of scope, get most efficient, and do the most good. But that's really, really challenging, because you're right, there are a lot of politics behind all of that. And I think one of the non-political but other hard points is that clinical threshold. It cannot just be a PHQ-9 or a GAD-7 that is the decision-making point for when a person is referred. And without collecting data and looking at that data, we are not well equipped to understand what that threshold really is.
All right. Thank you so much. And let's turn to some questions now. We'll take them the way they came in. Paul Buller asked Samantha, but all of you, about the comment on curricula in healthcare research and curriculum healthcare services that needs to be more interdisciplinary. Specifically, what would that mean? Any one of you, Well, Samantha, you're on the screen, so you take a stab at it first.
Yeah, for sure. So when I was a social worker, again, just a bachelor's in psychology, we had these care conferences. And where we literally sat at a table, and it was social work, it was the medical provider, it was nursing, it was your speech therapy, occupational therapy, your physical therapy, and it was even finance. And we sat down and we talked about, where is this person and where do they want to be? And what does that mean for each of us in our respective roles? And I think what we get out of most MSW programs is, hi, I'm Samantha, I'm your social worker, and I can tell you what I can do from my social work perspective, but I don't yet know how I can work with the rest of you in getting this person from where they are to where they need to be. And so I think like an easy logistical piece of that is have some clinical hours where interns or practicum students spend time in a primary care provider office with a primary care provider. Like have them shadow, have them work with administration so they understand the conversations, so can speak the language around program management, process improvement, productivity, all those fun things, so they can understand how what each of these other partners is doing impacts the ability for them to serve. And I feel like people would be very willing to help facilitate the development of a well-rounded clinician, because what we often get is clinicians who know their place and their place only, and don't speak the multiple languages that are spoken within a clinic setting.
Thank you. Thank you. Ryan or Philip, do you want to take a crack at what needs to be done in the educational preparation for some of our behavioral health clinicians?
Well, I'll just kind of add. So I teach health psychology to master's students who are going into healthcare, and I don't think there's a good understanding of what therapy is. So there's kind of this perception that when people are depressed, when their screener's positive, they need therapy. And if you don't know what therapy is, you create this weird kind of mysticism about it, in that it will make all this go away, and that you are incapable of doing some of those things, not only for your patients, but for yourself. So I teach what therapy is. I teach what CBT looks like. I teach what psychoeducation looks like. I teach DBT and ACT skills and mindfulness. Doing that stuff demystifies it so that providers can care for themselves like they need to be doing, because it's not an easy job. And it starts to really kind of pull back the curtain on what types of things can be done in 5 minutes, in 10 minutes in primary care, and allows us to then better determine who may need the higher level of care for those more kind of complicated situations where the primary care space just doesn't get us to where we need to go. So I don't know where it falls short, but when people make it into the healthcare space, they don't know the details of what therapy is.
Okay. Thank you, Philip. Ryan, you want to take a crack at that question?
I think it's one area where we can improve is on the professional identification around participating in behavioral health concerns. I was in the emergency department early in my career, and we're sitting around well-trained physicians, and they have, we have this massive spike in emergency department admissions, and they're saying, well, we're not trained in this. And I'm like, well, we better be, because you're some of the most educated people here, and the brain is attached to the body, and you're clogged up. So this is really important stuff. And they were going to discharge it to a 23-year-old who had zero training, 40 hours of training. And that was identified as a better prepared person to manage these really complicated behaviors than a physician. So I think that professional identification can go a long way. And I think on the behavioral health side, it is somewhat of a siloed training model. You're sitting alone with people a lot in the way you're trained. And so I think the training can evolve.
Thank you so much. And I just want to point out that Dan Ferguson of Yakima Valley College has posted in the chat that there is actually a place nationally, Nexus, where some of the interprofessional best ideas can be found. Well, we're having a great conversation, and we're going to run out of time. So let's try to take these questions in the order they came in. So from Patty Stauffer, She asks, the AIMS collaborative care model, I understand this is centered on psychiatric care. Is that accurate, or is there a role or place for psychologists in this model? I wish we had Kayleen Swart, Islam Swart from Eastern to answer that, but maybe Samantha can answer that as well from your background.
Happy to answer that. So the main relationship there from the primary care and the patient perspective is what the AIM Center calls the behavioral health care manager. In our models, that's an associate or a fully licensed clinician. You could replace that clinician with a psychologist. It's really a behavioral health trained person. So a broad variety of education and background there. The psychiatry piece comes through consulting. So your behavioral health care manager would have a weekly consulting time with that psychiatrist who would review cases and provide recommendations so that you get better, more consistent access to psychiatric consult and input. And you can manage through the primary care relationship more patients within primary care without having to refer out and kind of clog those referral lines. That's where the psychiatrist comes in that model.
Okay, so not sort of a first round meeting, not sort of a first round encounter. Thank you. Okay, this is from Richard Van to all three panelists. What evidence would be the most useful to make the case that integrated care works? Care outcomes, cost savings, payer acceptance. In your opinion, what evidence would be the most important to all stakeholders or the different stakeholders? So sure, all three of you may have some comments on that one. So Samantha, you're on the screen, you get first shot, and then we'll go to the other two. So what evidence would be most useful?
Well, for our payer relationships, actually demonstrating reduced total cost of care would be amazing. But the social worker in me would much prefer a clinical outcome. So maybe by chronic disease line. So for a diabetic, is the difference in my A1C different after I've been engaged in therapy? So I think that you could break out some key outcomes by diagnosis or disease line, in addition to total cost of care, and probably tell a pretty compelling story.
Right. We'll go to Philip next. What metrics would make the case most useful that integrated care works?
I'll stick with some PCBH classics and the consulting role. And we need to hear from our physicians, the medical providers, if they are more efficient in what they're doing. Also could be backed up through metrics in patient outcomes or cost of care. But I think primary care providers are the pool of information, and how their work looks is what we need to be doing. Like, if this helps keep primary care providers in the work, if it helps them manage a patient panel in a way that they wouldn't be able to otherwise, and if it keeps them liking their job, there is a tremendous value to that that I think needs to be measured. And it is an answer to a question that right now people seem to be really searching for. Our healthcare workforce is struggling, and to have good team members is such an important and a valuable piece to that care.
So if I can follow up on that for Richard's question then, Philip, I mean, are you saying that one avenue would be to actually take survey primary care providers on their job satisfaction? Is that what you're saying?
One of the biggest compliments I have ever been told is, if I ever leave this job, I would never take a job that doesn't have a BHC. That means a lot. And there are providers who feel that way. They've been in the, once they've been in the model, they love it. And I think to understand that, and to understand the value of job satisfaction in a place that work can be pretty grueling at times. And that's even before the pandemic. That's something we need to really get more details. I mean, testimonials are great, but I think the data behind that still is lacking.
Okay, thank you. Ryan, quick comment to Richard's question about preferred outcome measures.
Those are great. I just had one more that's sometimes important is just patient experience. Are they experiencing the healthcare system as a more welcome and engaging place, somewhere where you can get better within, would be important.
All right, yeah, can't forget the patient when we lead all our acronyms with that P for patient. All right, here's a question from Stephanie Goodenez, and I don't know if I pronounced your last name, Stephanie, correctly, but my apologies. Have any of your organizations partnered with home health agencies for specialized training to support homebound elderly patients or any specific programs? I'll throw that wide open. Anybody who wants to raise his or her hand? I see a head shaking from Ryan. Philip or Samantha, any home health connections?
What we've been able to do, I kind of mentioned us being part of a team and part of, educators. We have other programs in our organization who do some in-home services, and they are some of the most frequent askers of behavioral health training. They're in these homes, they're working with people, and it does not take long before people start to really share how hard their lives are. And so I think there's a really great opportunity that if you have people who are working in homes with patients, that they need behavioral health experts to, one, teach them what they can do, and two, teach them how to get those people connected to other services if that's what may be needed. But I know I've given many in-service trainings on things like suicidal ideation that come up during home visits.
Okay, Samantha.
I know we have pretty extensive relationships with home health organizations in the Puget Sound. Here in the Inland Northwest, we use them more in substance use. So like anyone who's on a long-term IV antibiotics, discharging them to a safe location and having home health follow up so that they don't have to stay in the hospital for 6 weeks. More in that realm, but on home health, I mean, we do have older adult services where our behavioral health clinicians will go into the home and provide, this is pre-COVID, provide care as well as following those individuals into hospitals, assisted livings, skilled rehabs, et cetera, for transition. And then we have personal health partners, which are non-clinical individuals who will do a lot of the facilitation for those higher chronic disease folks. So I haven't yet seen a very comprehensive model of all of those things kind of working in tandem, but that's a great call out.
All right, I got 2 more questions and we got about 9 minutes. I think we'll make it unless somebody pops up with another question. So this is actually a statement, but we could make it a question. This is from Tara James. She says, one thing we can improve on is psychiatric rotations and other medical residencies, such as family medicine, neurology, emergency medicine, pediatrics, et cetera. Quick response to that statement from Ryan, Philip, or Samantha. Samantha, you're on the screen, so go ahead.
Yes, you can. That's a great thing that we could do to improve.
Okay,
and
so
to Ryan's point earlier about that we better be trained, I think there is an aspect that psychiatric medications are not as scary as your PCP thinks they are. They can do a little bit more than they think they can. And if we're all doing a little bit, we can make sure the psychiatrists are helping in the situations that we really need them. So I would love it. I would love every primary care provider to be a little bit better at their mood stabilizers, antipsychotics, MAT drugs, stimulants for ADHD. Be awesome.
So we have 2 medical schools here in town, and you have 1 medical school in Yakima, Philip. So I hope that question gets around, and we'll see what some of the answers are. Ryan, do you want to give a response to that particular statement?
Yeah, I think it's a terrific idea. The more that we're getting people trained and then queuing into some of the biggest sort of challenges around the suicide epidemic and the opioid crisis that we're in. I mean, every specialty needs to be thinking about this because it's such a massive problem in our society.
All right. Well, we do have on the steering committee, we do have representatives from both medical schools. So maybe we'll bring that up afterwards and see what could what the response could be. So to wrap up with a real softball question, I mean that tongue in cheek. Brenda Stevenson, one of our co-founders, has posed this question. So good luck. Who wants to comment on the politics and culture of the health services sector and the major role it plays in developing, that is culture, in developing effective integrative models of care? Okay, so a culture question.
Yeah, sorry, I'm an extrovert and I'm confrontational. Yeah, like the culture that puts MDs and DOs on a pedestal, and the same culture and the politics that don't reimburse behavioral health for like services and other ambulatory service lines. The same culture that stigmatizes behavioral health as on a systemic level and makes it so that we feel like we're inherently less than our counterparts in the integrated settings where we work. Yeah, I'll comment on those. I don't know if that's what you meant, Brenda. I will say one of the most challenging things for workforce is the feeling of being subservient.
You are so on target. I'm chairing a dissertation committee, and that is the topic of the dissertation.
Yeah, I'm glad I'm not wildly off base, and it really is a fine line. And I bet, Philip, it sounds like your team that has really optimized that line and walks well on it. But it is a fine line to not be a doctor and to be high helpful and high appreciated and highly effective versus subservient and really just burning out, doing everything you can to feel like you're a part of the team and you're giving back. And that's what we see all over the place in integrated models of care. There's just chasms of lack of education, lack of empathy, lack of understanding. And it's so variable, the experience and the education that people come with to our programs, whether it's on the behavioral health side or the medical side, that you really never know what you're going to get into. And it's never an easy implementation because people can be so far away from really being on the same team.
Right.
You will hear from me.
Thank you, Samantha. So Ryan or Philip, do you want to take a response to Brenda's question about culture and how that affects delivery of care?
Yeah, I think one thing that I would like to say is maybe about the ways this could improve the culture of service delivery, because if you add more disciplines that can be opened up to people who have been excluded from participation in some of the service or some of the education programs. For example, there is a disproportionate number of white individuals with counseling backgrounds. And so if we have people who don't look like people in neighborhoods and we're saying, go get them for your mental health, I think that's going to increase stigma. And so opening this up can create different pathways for professions. So I don't know if that's exactly what that's about, but that's one area I wanted to take it. The second is about something that I can't remember. It's not in my brain anymore.
Okay,
it's gone. Yep.
We'll give you a second chance.
Yeah.
I think Philip's
maybe just maybe I can channel you here and see if this was your other item. I think my simple point is it's kind of time for fee for service to just die. Like the idea that the number of minutes you spend with someone is based on your reimbursement is so just backwards thinking, and it just really incentivizes some really perverse things in terms of what that looks like. And if we could just finally move on, and I don't understand the politics of this, but finally get payer systems to trust healthcare to treat people and do that through quality-based metrics and just be done with how many minutes did you spend with somebody, that I think would really shift the tides, and it would allow us to get there and to be innovative. But even in alternative payment structures now, some of these things are so entrenched in billing codes that are stuck on minutes. And as long as that happens, people are going to be watching the clock. That's what it's about. you got to hit the right number of minutes, and you got to make sure you're in the right code or get to the next code or don't fall short. And it's not good patient care. It's clock watching.
Okay. So I don't think we have any payers on the call, which would have been nice, but we would, had there been, I would have given them a chance to respond.
It's recorded, so you can have them come watch.
All right, I think we're at the end of our hour. I just want to say that Dan Ferguson has posted the link to integrated care and training, and you can see it under nexus.org. So any of you have an interest in that, click away. So I'm going to turn the mic back to our Ashley Beck, head of our steering committee, and you can just conclude here, Ashley, with any remarks you like.
Thank you to all of our panelists. I also took a lot of notes. This was just a fantastic discussion. We will, I guess for everyone, we'll be communicating about future events. We also see an email from us this week asking you to fill out a survey to give us feedback on what you liked about kind of this presentation style or tips for us to improve for future conversations. So just thank you all so much for coming, and a huge thank you to our panelists and to Paul Bowler, as this is the last event that he's planned before his retirement. So thank you to everyone, and have a great evening.
Okay.
Thank you, everybody.
Goodbye.